Hi, I'm David Luberoff, the Deputy Director of the Joint Center for Housing Studies, and I want to welcome you to the first of what we hope will be a series of online presentations focused in particular on issues related to housing and the COVID-19 pandemic. Before we start, just a couple of quick things. The Joint Center, as Chris Herbert noted in a recent blog, is going to be trying to focus both our blog and hopefully some of our events, our virtual events, on COVID-19 and the housing, the housing-related issues of COVID-19. We've started that in our blog yesterday. We published a blog by Don Layton, Senior Fellow, former CEO of Freddie Mac, on America's housing finance system in the pandemic, 10 stress points to watch. And on Tuesday at 6:30, there will be a conversation with Don and Chris Herbert, the Senator's Managing Director, on the housing finance system during the pandemic and beyond. Look at your emails and the Joint Center website for more information about that. If you're a student, I just want to note that we've extended the application deadlines for summer fellowships and our student research support program, which both support graduate students at Harvard, particularly those at the Kennedy School and the Graduate School of Design. Today's presentation is by Samara Scheckler, a Joint Center postdoctoral fellow who will be speaking on caregiving during disruption, using the opioid epidemic to discuss caregiving changes during large-scale social disruptions. Samara comes to us from the University of Georgia, where she received a PhD in public administration and policy, and is working on a variety of projects related to community-based aging. As her title suggests, she's going to present work she's done on caregiving during the opioid crisis, and then, as the title indicates, she graciously agreed to extend some of the framework and structure that went into that research to think about caregiving during other large-scale social disruptions, such as the current pandemic. Samara is going to speak for about 25 to 30 minutes. If you have questions, feel free to email them to the Joint Center's main email address, which you can find on our webpage, jchs@harvard. Actually, I'm going to go back and check that. I'll give that to you at the end, and we will find a way to respond to them. Unfortunately, we are unable to do this at the moment live and take questions live. But this is a terrific presentation. I'm looking forward to hearing the final version. I've seen some of the drafts, and now I'm going to turn it over to Samara. It's all yours.
Thanks so much, David. I'm looking forward to sharing this work today, and I hope that this platform will be a useful tool for starting a discussion, even if we're not sitting in a room together. When I started this research, I was really thinking about compounding disparities and what it means for older adults who find themselves in multiple disadvantaged categories and how that impacts their health and housing situations. And in our current moment, I've been encouraged and inspired to expand my thinking into what it means when social disruptions happen and someone who is in this demographic is having to cope with a world around them that is changing. So when I started this work, I was able to work in an office. I could walk down the street and get a coffee. I could send my kids to school for the day. I could plan ahead and know that I could take a trip when I scheduled it and wouldn't potentially have to cancel it because the world was so unpredictable. Just as my own daily routines and expectations have been upended, as I'm sure have yours, we also have changes to our informal caregiving system that I'd like to talk to you about today. I'd like to think very carefully about the resources that we might knit together to support older adults in this moment. So the format of the presentation today, I'll start off with talking about caregiving, explaining what I mean when I'm thinking about networks of care, because I'm sure we're all coming from different disciplines, and I want to make sure we have a common understanding of the size and scope and the type of tasks that we're thinking about, and what it means to have this network disrupted. We'll use the opioid use disorder epidemic as an example of a disruption, and then we'll move on to think about how network disruptions might occur during the novel coronavirus experience that we're all in the middle of right now. So what is care and why is it relevant to housing? We could define caregiving as any activity that supports independent living and self-care. This caregiving can occur in a home, such as cooking, laundry, or housekeeping tasks, or outside the home, such as banking or grocery shopping. Caregiving might happen from afar, so someone might be an advocate or a financial manager for someone else without actually being in the same space, or it might be very intimate. It might comprise dressing or feeding tasks, personal grooming. If an older adult has unmet caregiving needs, that can lead to health impacts. There are, we know that folks who have unmet needs are at risk of inpatient hospitalization, also of needing institutional care or moving into a nursing home. So their housing situation, their community housing situation can become unstable when this informal care network is disrupted. At times of great social disruption, like we're experiencing right now, we're going to have to reconsider the balance that we keep in this country between informal and formal care networks. And we'll talk more about that. Let's think now about who needs care in the US. So in the US, we rely very heavily on unpaid family members and friends to provide support, but let's wrap our minds around who actually needs the support. So all children are going to need some kind of care, just by definition. Children are dependent on adults to provide some kind of care, although of course that's going to vary depending on the age and skill level of the child. Just like with any other person who needs care, there's going to be a unique definition and set of needs for that person. For adults age 18 to 64, we know about 10% of these folks have a disability. And this might be a sensory need, a challenge to their concentration, memory, decision-making. It could be physical. They might have ambulation issues that make it difficult for them to climb stairs or walk. Or they might have some global needs in the areas of self-care or like dressing or bathing, independent living needs such as running errands. In adults 65 or older with a disability, the proportion jumps up quite a bit to about 35% of this group, and the more we concentrate on older adults, so as we track that farther, we're going to see a higher proportion of the group needing support and care. Let's now think about relationships in the network of care. So who's actually providing this care? So first of all, I think it's worth noting that these informal networks of care are by their very nature hidden from public administrators and health systems. There's no quick way to find them if there's a community-wide disruption. There's no easy way to know if someone's caring for their neighbor or if an adult child is grocery shopping for their parent. We know that caregiving relationships are not mutually exclusive, that they may be multi-directional. In other words, care may be mutually provided to multiple people at once or to one another. But for simplicity's sake, we're going to talk about caregiving in a set of categories. We'll look at adults or giving care to an older adult or an older adult giving care to a grandchild. So we're thinking about care of an older adult. We know this comprises about 34 million Americans. 34 million Americans provided unpaid care to an adult aged 50 or older in the year 2015. This care is necessary to keep the older adults stable in their health and their housing. About a third of these 34 million caregivers are meeting short-term needs. So this might be post-surgical, it might be coping with a sickness or some other termed event. But 3 in 5 recipients of care have a long-term physical condition. So it's not going to be a matter of days, weeks, or months. It's going to be likely a matter of years. 6 in 10 of the caregivers are performing medical or nursing tasks as part of the care that they give. So we're talking about perhaps care that is skilled or very intimate. 42% of caregivers of an adult are caring for their own parents. Time spent caring will vary dramatically depending on the need. So family caregivers tend to spend about 24 hours a week on care, but 1 in 4 caregivers will spend 40 hours a week or more on the care that they provide. The average spousal caregiver, person caring for their spouse, will fall into this category. And the average duration of care is about 4 years. So let's think about now grandparent caregiving. So at least 2% of US children lived in a household with a grandparent but no parent. Over 2 million caregiving grandparents exist in America in any given year, caring for over 5.5 million children who are primarily in that care. Broken down, 1 in 10 grandparents have raised a grandchild for at least 6 months. Of these, 1 in 5 cared for the child for 10 years or longer. So it's quite a commitment that's made. Half of custodial grandparents started caring for a child who was under the age of 3. So some of these children are quite young and will need quite a bit of care, support, and attention. Why does grandparent caregiving happen? There are a wide range of precipitants: health, mental health, economic, vocational, or social challenges experienced by the biological parent. However, substance use disorder by the parent is the primary reason that grandparents become caregivers. It's associated with 34% of formal removals by the state of a child from their home. And these children who move in with their grandparents due to substance use disorders are likely to be vulnerable. They're more likely to have experienced some kind of trauma. Just the removal itself is certainly traumatic. And if the state is removing them, something may have happened. This child is likely to have been or may have been exposed to substances in utero, for example, and that has lasting developmental consequences. So these are more complex relationships that the grandparent caregiver may have to navigate. Family caregiving or care given to an older adult or a parent is almost always informal, unpaid, doesn't go through administrative systems, but grandparent caregiving can be formalized through Child Protective Services, so the state can oversee the relationship and approve of the relationship in some cases. However, most grandparent caregiving is thought to be informal. One estimate puts the proportion of grandparent caregiving as 70% informal. So it's there are formal caregiving relationships that we can study, but we have to know that this does not capture the majority of these relationships. So what are we worried about with this caregiving network and a social disruption? So a disruptive event is likely to impact the informal care network and force some kind of behavior change that could impact housing and health of the care recipient. So this could look like a large-scale economic change or recession that forces change in employment status and caregiver availability. It might be a crisis like a local weather event, a tornado or a hurricane that turns a caregiver's attention away from caregiving tasks, or forces a caregiver to attend to other matters such as children. We'll look at epidemic level substance use and how that might impact the caregiving experience. And we'll think a little bit about pandemic disease and the new habits that that might force. So we're going to talk now a bit about opioid use disorder and caregiving. This is an exercise that will force us to look away from the adults with opioid use disorder and refocus our attention on the ripples that occur in the informal caregiving network. And then, of course, we'll turn our attention to the informal caregiving network and how it may be impacted by the COVID-19 disruption. So we'll think today about what we can learn about the caregiving network in the presence of high opioid use. Specifically, did grandparent caregiving increase in areas where opioid use was very high? And can we identify compounding disadvantages for the grandparent caregivers who were part of this informal caregiving network, who filled in the gaps as the network of care shifted? And then we'll think about how this can prepare a response to the novel coronavirus as we anticipate disruptions in the informal care network. Why do we suspect that there's going to be vulnerabilities or changes to this informal caregiving network? First, let's think about the size and scope of the epidemic level use of opioids. So prescription opioid related deaths nearly tripled over a period of 15 years. 20% of deaths in 2016 of people between the ages of 24 and 35 were attributed to opioid use. So this is pretty seismic impacts. We can also use basic demographic information to suggest that there might be a vulnerability. Looking at age overlaps, we see that the mean age of person receiving inpatient treatment for opioid use disorder is 36, which falls squarely into the age demographic of a person who may be caring for an older adult or caring for a child. So about half of people caring for an older adult are 18 to 49. And the median age of having that first child is around 26. So we might feel concerned that there are disruptions to these caregiving relationships. And we might feel concerned that when a caregiver is removed from this informal network of care, we will see vulnerabilities in health and housing stability. Particularly when we see that a whole community has been disrupted, we might expect a larger scale reshuffling of the informal caregiving network. So what do we know and what don't we know? Informal caregiving and opioid use disorder are both very hard to study. They're both hidden activities. We don't see them happening in our administrative records, and it's very hard to track them to the person. Opioid use disorder is by its nature hidden, given that it's an illicit activity. And even when you're looking at formal removals from home, from a home of a child, there's very little consistent policy or protocol, even within states, on how the reason for the removal is reported. So a family that is experiencing a person with opioid use disorder, the removal may be listed as neglect, for example. So why are we worried about parental substance use driving up grandparent care? We will worry that research has told us that grandparent caregivers tend to exhibit higher rates of depression. This particularly occurs at the outset of the caregiving relationship and at the end. So in those transitional moments, there are mental health consequences for the older adult. Grandparent caregivers tend to decrease their exercise, and we see an increase in obesity as well. And in general, we see that grandparent caregivers report as less healthy and experience more difficulty completing various tasks. There is stress involved with grandparent caregiving, and that has health consequences and other factors that could destabilize the grandparent caregiver, his or herself. So let's talk about what I did. First, I used individual level data to find grandparent caregivers. In the census and the American Community Survey, there is actually a question asking if the respondent is a primary caregiver for a grandchild. So that's very helpful for revealing this hidden population, which may not appear anywhere else in the records. So that was my primary variable of interest. I controlled for the age of the individual, the household income, education, and marital status, as well as race and ethnicity. And then I also looked at regional level variables, including the rate of opioid prescription, which we'll talk about in a moment, as well as the area's median income, the unemployment rate, poverty rate, and the trends over time and geographic trends. So this graph is showing us the difference between an area of high opioid prescription rate use and low opioid prescription rate use. So let me first explain the area, and then I'll explain the graph. So we're working in public use microdata areas, which are, these PUMAs are defined by the American Community Survey as a geographic area ranging between 100,000 and 200,000 people. They don't have any necessarily common governance or anything like that. They tend to respect county boundaries, but multiple counties may be mashed together into a PUMA, or single large counties may be divided up into multiple PUMAs. So it's hard to talk about PUMAs as discrete entities because they don't necessarily have common governance or other things in common. However, I collected all of my geographic information at the PUMA level because that's the most micro level I could look at for the individuals in the American Community Survey. I ran this two different ways. First, I looked at just the impact of a continuous impact of increasing prescription rate. And then I also looked at what happens when a community or a region is one standard deviation higher in the rate of opioid prescriptions that was occurring. So prescription rates are very closely related to illicit opioid use. In 2016, prescription opioids accounted for about 40% of opioid-related overdose deaths. And the geographic variation in prescription rates is larger than the variation of any other healthcare service. The total number of prescriptions dispensed, opioid prescriptions dispensed, peaked in 2012 at 255 million scripts. And it remains today high in some counties, although it's come down in general. So in 2015, there were 6 times more opioids per resident dispensed in the highest prescribing counties than in the lowest prescribing counties. So what we're looking at in this graph over time is the difference between the average rate of opioid prescription fills and the the standard deviation above that average rate of opioid prescription fills. So we're going to compare these two different kinds of geographic areas, the areas with high script rates and the areas with lower script rates. County level characteristics, by the way, such as rural versus urban, income level, demographics, this only explains about 1/3 of the difference in these prescription rates. And we do find that there's a significant difference between the high prescription rate regions and the rates of grandparent caregiving. We see that caregiving is about 2.5% more likely in a high script PUMA. You're about 2.5% more likely to be grandparent caregiver if you're living in a high prescription rate area. Looking at the bar graph, notice the bar on the right shows us that more grandparents are living in high prescription rate PUMAs. So even though these areas, the high prescription rate PUMAs only represent about 10% of the population, we see 15% of our grandparent caregivers living in these areas. I will say there are about 2 million grandparent caregivers represented each year in this data. So let's talk a little bit about our grandparent caregivers, think about their demographics, who they are. This blue bar at the top shows us that about 50% of our grandparent caregivers are between the ages of 50 and 59, as compared to 40% of the general population. So our grandparent caregivers are younger in general than the population at large. However, even that smallest bucket, the age 70 plus, represents about 300,000 caregivers every year. So there are older grandparent caregivers, even though they are heavily weighted towards the younger end of the grandparent spectrum. Grandparent caregivers are also more likely to be employed than other adults age 50 or older, which makes us feel concerned that these folks are trying to balance jobs and caregiving, new caregiving in their lifestyle. About 65% of grandparent caregivers are married, accounting for about 1.3 million caregivers every year. Looking at income, we see that grandparent caregivers tend to have overall lower income than other adults age 50 and older who are not caregivers. So the average income, if they're living in a high prescription rate PUMA, is even lower than that. In a high prescription rate PUMA, we see about $58,000 a year being the average income, as compared to about $70,000 a year for grandparent caregivers living in all other areas. Notice also in general, on the right-hand side, on the right-hand graph, that the right-hand cluster of bars is showing us a range of income buckets. You can see the dark blue bar on the left and the light gray bar on the right show us the lowest income and the highest income individuals in the sample. These are all caregivers. So those in the high script PUMAs on the right are more likely to be in that dark blue category of less than $15,000 a year, or the red category of $15,000 to $30,000 a year, and less likely to be in that gray category of $75,000 a year or more. We also see some differences in the tenure of older adults who are caregivers. Overall, compared with adults 50 or older, grandparent caregivers are more likely to be paying a mortgage or to be renting. They're about 13% more likely overall, 12% more likely overall to be paying, which accounts for about 1.5 million family caregivers overall who are still paying rent or still paying mortgage. In the high prescription rate PUMAs, they're about 4% more likely to rent than if they were living in other areas. On balance, grandparent caregivers are about 5% more likely to be moderately or severely cost burdened. This means that they spend 30% or more of their income on housing related costs. So this accounts for about 700,000 grandparent caregivers each year who are cost burdened, 300,000 a year who are severely cost burdened. So we're starting to feel concerned that these folks who may be trying to maintain a job, are newly caring for children who may be high need, are also dealing with the financial challenges themselves. Let's look at health next. And we see a difference in the vulnerability of our older adults and their health who are grandparent caregivers. Overall, about 20% of caregivers report difficulty ambulating, getting around, walking. So that's about 400,000 caregivers. Looking at the two blue bars, the left-hand blue bar shows us the grandparent caregivers with difficulties in all PUMAs, and the right-hand blue bar shows us folks with difficulties in high script PUMAs, and this is aggregating all difficulties. So there are about 77,000 people, or about 25% of grandparent caregivers living in high script PUMAs with difficulty ambulating. The line graph on the left shows us the blue line at the top are ambulatory difficulties for folks living in a high script area, and you see that consistently drops down. Ambulatory difficulties for folks living in other places are consistently lower when we're looking at grandparent caregivers. So in sum, this disruption of an informal care network is associated with other older adult vulnerabilities. We feel concerned about financial stability. We feel concerned about the health. We're more likely to find our grandparent caregivers as assuming informal caregiving responsibility if they live in a high opioid script rate area. Their income is skewed lower. They're more likely to still be paying on a mortgage. They're more likely to be cost burdened, and their health is generally worse. So we found that there are geographic pockets of vulnerability that could lead to instability. And we need to consider whether we have formal resources that can fill in the gaps of this informal care network that has been disrupted. So this has been a retrospective exercise in identifying vulnerabilities that arise in the informal caregiving network as the result of a disruption. Now I'd like to consider the moment we're in. We have heard a lot about the danger for older adults living in nursing homes, which is an incredibly vulnerable group and represents about 1.4 million over adults. However, there are over 2 million grand families, and many represent a hidden node in a caregiving network, which may be disrupted during this coronavirus epidemic. So let's reconsider what might happen, what we might need to do to rebalance the formal and the informal supports that we tend to rely on in our caregiving networks. So let's return to the questions that we might want to ask when faced with a social disruption. Thinking about grand families, COVID-19 represents a loss of some kinds of informal care and support. So these already vulnerable families, by finance, by health, may lose additional supports in the face of this social disruption. They have lost or changed some formal supports, such as schools. The children are no longer attending the schools, which may act as essentially respite care or childcare while these older adults are trying to work. With shelter-in-place orders, folks also lose a measure of their independence and autonomy. So particularly for the grandparent caregivers who are in the highest risk demographic by their health or by their age, they may not feel safe to leave their homes and do the tasks perform the tasks that they normally do. So yet it's going to be more difficult for caregiving grandparents to isolate, which puts them at risk of serious illness, of catching this coronavirus. Grandfamilies represent a disruption in the informal care network. The most common directions of care, of informal care, aren't occurring, and informally the grandfamily forms. They may have fewer people who are available to step in and provide care in their stead. We worry about their health and their housing structure. We worry about increased anxiety as the grandparent who is providing care begins to think about what's going to happen to the child in the event that the grandparent gets sick. We worry about the grandparent having to figure out who will care for the child if the child gets sick, because it may not be safe for the grandparent to be present and caring for that child. If the caregiving arrangement isn't formalized or permanent, that grandparent may be worried that the child's going to be taken away from them and put into a less desirable situation. And the children themselves may be worried about the situation and about their grandparents. We also feel concerned about loneliness and isolation occurring. Loneliness and isolation themselves put the grandparent at risk, at higher health risk. They're associated with a 29% increase in risk of coronary heart disease, 32% increase in the risk of stroke. So we feel concerned that a grandparent who is caregiving, even though they have the grandchild in their home, may feel more anxiety and more isolated than they otherwise would have. Because ultimately, this novel coronavirus will compound existing disparities. The house may be too small for the family. Grandfamilies in rural areas may have even less access to food, to transportation, to social supports. Technology is more likely to be spotty for them. Grandfamilies that include an undocumented member may be afraid to go to request public services or supports in this time. So parents without alternatives may also continue relying on grandparents to provide some care. So even if the grandparent isn't the primary caregiver, they may still be putting themselves at risk to support the family informally and care for a grandchild. Or alternately, a grandparent who had been providing informal care, may lose access to that grandchild for a period of time, and recall that these times of transitioning in the caregiving relationship are associated with a risk of depression. So let's think quickly about the greatest concentration of grandfamilies. We tend to see grandfamilies most commonly in Florida, New York, California, and Texas. These states are all under significant watch as the novel coronavirus unfolds. As of yesterday, when I was looking it up, I found that New York had been testing at a rate of 5,300 tests per million people, all the way down to Texas, which has been testing at a rate of 465 tests per million people. So we worry that as health declines compound in these areas, the crisis for grandfamilies is going to compound. And I would advocate that we want to empower a single statewide office in each state to use the administrative resources to locate hidden caregivers, hidden grandfamilies in that state who have been informally providing this care, and offer formal systems to knit back together some of this disruption. So through the schools, through existing social service enrollments, someone has to consciously seek out these grandfamilies and assign a care coordinator to broadly examine the financial situation, the medical situation, the social situation, see what kind of resources are lacking, and make linkages as is appropriate, ensure respite is available even if it's virtual, and particularly ensure a plan is in place if anyone in the household gets sick, so that they can also ensure safety by co-constructing a viable shelter-in-place plan, but give the entire family the peace of mind to know that they have a plan if the COVID-19 touches their home. We also need to be taking very good advantage for these families of mental health and physical health services offered through telemedicine, and consider bringing volunteers into the picture to virtually check in with these families and make sure on a daily basis that they have what they need. So I'm going to put up some resources now of systems that I think should be carefully considered, formal systems that can take the place of all of the informal care that we currently expect from grand families, but may not be feasible or realistic in this moment of great social disruption. So with that, I will end the presentation, and as David said, I look forward to continuing this conversation, and we've had a week to think about it. I look forward to hearing your thoughts and increasing the depth of the conversation and our understanding of how we can innovate in this area and what kind of supports we will knit together to make sure that all of our older adults make this transition safely. Thanks.
Thank you, Samara. And it's unfortunate, I think, that you don't get the opportunity to hear both immediate feedback, but also appreciation of a really comprehensive and thoughtful piece of research. And I think the framework from the opioid research, which in and of itself is hugely important, is really wonderful about helping us think about this idea of who's vulnerable, what are the care systems that might be affected, and how might that in turn affect health, and think about responses. As I said at the beginning, look forward to the Joint Center for some future online activities. We're still trying to figure out exactly, as I also said, we're still figuring out how to best make use of this. And if you have questions from this presentation, please email them to the Joint Center, jchs@harvard.edu. That's jchs@harvard.edu. And we'll collate some of those questions and figure out a way to post responses. It might be by video, it might be via a text, and we'll let folks know when we've done that. But again, I want to thank folks for joining us in virtual reality, or whatever this is. And particularly thank you, Samara, for a really thoughtful and thought-provoking presentation. Thanks a lot.